Hello, everybody. It's like it's time. My name is Tuktamyshov. Uh, I'm visiting from US. Uh, I practice general medicine. I work in the hospital, and my job description is hospitalist. So I see a wide variety of patients. Okay, and today we'll talk about uh, tuberculosis. So it's pretty rare disease in US. We'll talk about that a little bit later. But unless you're infectious disease, it's something you need to consider like frequently, but most of the time the diagnosis will be something else. But it's important to consider that because um, it's highly contagious if you, especially if you miss it, if you don't isolate the patient, and then if you don't treat in timely fashion, it may actually spread to other people. So the objectives for today is learn about epidemiology of TB, like which countries, where, how frequently it happens. Talk about the microbiology of Mycobacterium, how is this bacteria different. Uh, we'll talk about pathophysiology. We'll talk about different types of TB. It's primary TB and reactivation, uh, and discuss diagnosis of TB, different types of them. And then we'll talk a few words about treatment of TB. I think most of the time, if you diagnose TB, you will be involving infectious disease specialists. So at least in US, like he will not be the only one treating the patient, and then there will be cases like when there is some resistance, and you'll have to figure out with infectious disease team the optimal treatment. Okay. Uh, just a little bit few words of introduction. So TB is a disease caused by Mycobacterium tuberculosis, which it's ancient like old disease, which uh, even mummies from Egypt, they have some presence of TB in their bodies. In ancient Greece, it was described as well by Hippocrates. Good thing it's curable, but it can be fatal if not treated. So it's pretty common, although overall in the world, to be infected with TB, and it affects approximately 1/3 of human race on the Earth. Um, Usually affects the lungs, but that's not the only organ which can be affected. Okay. So this is the incidence. So remember, incidence is the its amount of new cases, right? So you can see that most of the cases include Africa and Asia, uh, and then the, the islands. So the prevalence, how much like active cases you have, it's shouldn't be too much different from this. So why is this important? So if you have a patient who comes from certain areas, certain country, and has certain symptoms of suggesting TB, the TB will be on your differential, okay? Like a little bit higher than somebody comes from US or Australia, comparing to somebody who comes like from Mongolia, which is like dark green here. So a few words about Mycobacteria. There are different types of Mycobacteria, okay? We'll be talking primarily about Mycobacterium tuberculosis, which primarily the human type, Mycobacterium. Uh, Bovis is not very common. It was historically it was a little bit more common when milk wasn't pasteurized in the past, like last century and earlier. Uh, there is also Mycobacterium BCG strain, which is used for creating of vaccine. There are other types of mycobacteria as well, which is lepra, which is separate disease, and atypical mycobacteria. MOTT means like mycobacteria other than TB. So you need to know about this because on the microscope, if you stain, they look kind of the same. So you'll not be able to tell the difference what kind of mycobacteria it is, but and diseases like caused by this mycobacteria, typical mycobacteria is like a different. So So to better understand why TB is such a difficult disease, we'll need to understand that it's how is it different from other like other bacteria. So it has a, you can see on the wall, it has a peptidoglycan, which all the bacteria have, but it has some additional layers, which allows it to survive inside the cell, outside the cell, and cause different pathological processes, which allow it again to survive inside our body. Uh, Mycolic acids is another layer which uh, helps mycobacteria to survive. In granuloma, mycolytic acids, they give signals to macrophages and then basically prevent digestion of them. So, and then we'll be talking about acid fast all the time. So what does it mean? So normally, if you any bacteria like gram positive, gram negative, like you stain and then you do decolorization, which with the acid, the stain goes away. So, but it works differently with the mycobacteria. So here on the first screen, you see that the, the stain is applied to mycobacteria, and you see different types of bacteria here. You can see the cocci, which are round bacteria, and then mycobacteria, which are long rods, and then you fix the stain, and then you apply the acid, and then you see the mycobacteria, they retain the stain, and then other bacteria, they lose the stain. Again, because of this like thick wall, once the stain is in, it's difficult to remove it. And then if you apply different stain, like a dark blue, which goes to the non-acid fast bacteria, and then they're going to look dark blue, but mycobacteria remain the same color. So that's what it means, acid fast. And the same mechanism, the same sequence of staining is used when you do staining for the sputum or any other tissue from the body. So, few words about transmission. So, TB is a airborne transmission. You remember there are two kind of ways uh, pathogens can transmit through the air. One is airborne, which is smaller particles, and then they remain in the air, and that they can travel longer distance. And there is a droplet transmission, which is a bigger particles, and they don't can go too far, and they go to ground like pretty quickly. And then simple mask is okay, is effective enough to prevent droplet transmission. But for the airborne, you need the different mask, which sits tightly on your face. And so the precautions will be different. So there are a few factors which may increase the risk of transmission. So for example, if somebody have untreated pulmonary or laryngeal TB, laryngeal because there is more vibration there, so you're going to create more like airborne particles. If there is a presence of cavitary lesions because there is more mycobacteria there. Um, and then if somebody is sputum positive for the mycobacterium, then those patients also will have high chance of transmitting. Actually, sputum positivity is used like in treatment, like to decide when you're going to stop isolation. And then the longer and the closer is the contact, the high chances the mycobacteria will be transmitted to somebody else. So what happens with what is natural history like of TB? What happens if somebody just gets it? How it happens that the 1/3 of the world is having TB, but doesn't like seem to be such a big problem? Uh, so what happens? So if somebody get exposed to TB, about maybe 5% get like no infection. They just like clear it, and then they don't have anything left, any mycobacteria left. There is another type is which is the most common scenario is a latent TB, and there is a new name for latent TB. It's called TB infection, but I think both of them still used, and you're still gonna meet see like latent TB is more frequently used comparing to TB infection. So here you will have no signs of symptoms of disease, but if you do immunological tests, you will see that the mycobacteria present in the body, and then you can do tuberculin skin test or interferon gamma release test. Okay, and then when it goes into latent phase, there is a lifetime risk about 5-10% that the TB will become active again. Okay, uh, the highest risk of this reactivation is within first couple years. For example, like I don't know, like 5%, another 5% is for the rest of your life. Okay, and then primary TB disease is when you have infection, like which starts right after contracting the mycobacteria. So a few words about the pathophysiology, what happens. So if somebody's coughing up mycobacteria, it get inhaled by another person, and as with any other infection, the innate immune response happens first, which is not specific. Okay, so body reacts to any viruses, any bacteria uh, gets to the body. There is a attempt to eliminate it, and then sometimes it works, sometimes it doesn't. So macrophages will be like one of the first cells, uh, and lymphocytes and neutrophils to go to the site and try to like kill the mycobacteria. Uh, Again, as you know, like most of the people will go to the latent TB, and because this innate immune response is not very effective, and granuloma starts forming. So you can see in the middle there is a formation of granuloma. A lot of cells like attracted to the area. It's the granuloma of TB. It's called caseous granuloma because there is a like cheese-like caseous material in the middle of the granuloma. And then when you see on the exams on the history presentation of the like they will tell you is it like caseous granuloma or not. Okay, so that helps to differentiate. If it's not caseating, it's probably they want to know you that it's not TB, like for example sarcoidosis or something else. Okay, so all these cells attracted here. So the benefit of granuloma kind of benefits both TB and then human body. So it doesn't allow it helps to localize the TB infection. So it's not killing you, but it's dormant. Okay, so you on one side it helps because patient doesn't have symptoms, it's just kind of living there without any kind of problems at least for a while, and it helps TB mycobacteria because it still has a chance to get reactivated. So which potentially may happen again, like 5-10% lifetime chance, like for under different circumstances, like if somebody gets malnourished, get like cancer, chemotherapy, HIV, immune system goes down, the granuloma may rupture, and then infection starts spreading. People develop pneumonia, like cavitary lesions, and then the cycle repeats itself. So, few words about the Mycobacterium virulence factors. We mentioned some of it a little bit before. So, these factors they facilitate pathogen survival within the host and then transmission. So, it's it survives for a long time outside the host. There is a cell wall components which prevents it from dying, from drying out. It allows intracellular survival. So there are virulence factors for that. So like it's kind of eaten by macrophages, but instead of being killed, uh, it doesn't get killed. It may affect the macrophage certain ways. Some of the macrophages may turn into like foamy cells, and then they cannot kill it like effectively. Um, and then granuloma formation, and again this extracellular survival. Bacilli remain dormant, uh, and then there is a if any like stress for the body, they may get reactivated. So it may disseminate in the host. There is a direct spread through lymphatics or bloodstream, uh, and then if you're really interested, like you can read like a lot of articles dedicated just to the immune manipulation of the mycobacterium. So it affects how the body is reacting, like it affects the inflammation and anti-inflammation. So it decreases the inflammation by its pieces of the cell, and then it increases anti-inflammatory cytokines. Okay. So again, this is like granuloma. This is it makes it different from other infections. So this is just like the schematic picture of what happens in granuloma. There are different cell types. You can see in the middle there are the mycobacteria, and then all this all these letters. This is the type the pieces of mycobacterium which affect the cells around it. So you can see there's a macrophages which attract it first, and then there's a macrophages developed with the giant cells, which and then there is a necrotic tissue in the middle, and there is the layers of the dendritic cells, and then other types of macrophages and B cells come and try to, uh, as you remember, like information presented to B cells so they can produce antibodies, but antibodies are not very effective to eliminate uh, mycobacteria. So what is granuloma? It's amorphous mass of the immune cells, which includes macrophages, monocytes, neutrophils, natural killers, and other cells aimed at restricting microbial spread. So at the same time, it allows mycobacteria to survive because although it's limiting, it doesn't really kill all the mycobacteria. So there is a central necrosis, caseation uh, is found frequently. So what are the symptoms of TB? So in general, all the symptoms can be divided into local, which secondary to mycobacteria affect, bringing its effects into the lung itself, and it has a systemic effect. So, of course, if you have inflammation in your lung, then you may develop pneumonia. Pneumonia may create cavitation. In the cavity later, aspergilloma may develop. Um, if the cavity is close to esophagus, you may develop bronchoesophageal fistula, which is connection between the airways and the esophagus. If inflammation is close to pleural space, the pleural effusion may develop. It may develop empyema if the infection spreads to the pleural cavity. With this inflammation and then pleura being affected, patients will start having shortness of breath. Because of inflammation in the airways, you will have wheezing on the exam, or may have. If the pleural cavity is affected, then patients may develop pleurisy, which is like pleuritic, like kind of pain in the pleura, because pleura is sensitive. You remember there is no like pain sensors in the lung itself, but there is a lot of pain sensors on the pleural space. And then if there is a continuous inflammation happening in the airways, bronchiectasis may develop. It may erode into smaller vessels, so people start bringing up blood, may bring up the blood. It's called hemoptysis. And then there will be like phlegm production. It may cause the local inflammation as well, involving mediastinum. Okay, so these are processes happening in the lung itself, and then TB will be affecting the rest of the body. It doesn't happen immediately, but as it continues, it can give hypersensitivity reactions, which some of them may cause symptoms like polyarthritis, but some of these reactions are used to diagnose or to find out about TB. It's reduced a lot of TB process results in increased toxins and then kind of more like a hectic condition for the body. So it starts causing anorexia, weight loss. The inflammatory response from the body will also cause fever, chills, night sweats. Um, so these are generalized symptoms. They don't develop immediately. It takes probably weeks and few months before patients start feeling them. So primary TB. Primary TB is when you have when patient gets the mycobacteria inhaled, and then this is the first time ever the patient have a contact with the mycobacteria. and that's called primary TB. So constitutional symptoms would happen here. Fever in about 70%, usually low grade, and then may last up to 2-3 weeks. Patients will have night sweats, weight loss. Uh, some people will have a pleuritic or retrosternal chest pain. So pleuritic pain means the chest pain, which is worse with a deep breathing. Okay. Uh, Patients will have cough, and then chest X-ray can be normal. Uh, and then in general, chest X-ray can be anything but the TB. And then in this case, it's frequently normal. So hilar lymphadenopathy can be seen. Pleural effusion sometimes can be seen 30%. Consolidation, again, 1/3 of the cases. If you do CT, it's same as above, but it's more sensitive, more specific. If it's a miliary TB, which is type of the primary TB, which is pretty bad, may see miliary changes, but patients usually pretty sick. If miliary TB happens, solitary cavities can be seen more frequently if you do CT scan, and then pleural effusion the same. So you see, this is the primary TB. This is called, you see the consolidation in the left upper lobe. And then you can see a little bit lymphadenopathy, like increase the density in the hilar area on the right side. So combined, all this called the GON complex when there is active site of inflammation and there is lymphadenopathy. Sometimes you can even see the track going from the area of inflammation to the hilar area. So all this combined called the GON complex. So it may happen with a primary TB. Okay, that's a sign of primary TB. So this is another type of primary TB, which is I mentioned it's called so what do you see here? Hmm? Yeah, yeah. So milia, it's kind of small seeds, and then with miliary TB, you can see like small, tiny, like spots all over the lungs on both sides. Patients are usually pretty sick when miliary TB happens, uh, and that's how it looks. So both sides. And this is CT scan, which shows the enlarged lymph nodes, the arrows. It's hilar lymphadenopathy. So it's more difficult to see it on the chest X-ray because the lymph nodes could be behind the heart, behind like the bones may be hiding them, so you may not see them very well. But if you do CT, you'll see them better. So here's another case which actually generated by ChatGPT. So let's see. 47-year-old male presents with 3 months history of progressively worsening cough. Initially, cough was dry, but has become productive over the past month. Occasional blood tinged sputum. He also noticed experiencing low-grade fevers, night sweats, weight loss 10 pounds in the last 2 months. So this is kind of subacute process, right? It's not like happens for 3 days. It's already going on for 2-3 months. The cough is most pronounced in the mornings and is occasionally accompanied by mild pleuritic chest pain. He denies significant shortness of breath at rest, but his fatigue has increased. Past medical history, hypertension. So social history, he moved to US from Russia at the age of 12, never smoked. His only medication is lisinopril for hypertension. And then there's a temperature 100.2 Fahrenheit, and on exam you see crackles at right upper lobe. So what do you think is the diagnosis? Yeah, what type of TB? So when do you think he was exposed to TB first time? Yeah, the part of the history is that he's from like one of the countries where there's a high incidence of TB. So they're trying to say like the patient comes from Russia, so probably was exposed there. Certain point, maybe like 10 years, 20 years, maybe in childhood, and probably had this dormant latent TB, and now something happened and then it's get reactivated. So it's like a reactivation TB. Okay. If there is no, it could be difficult to say if it's primary, sometimes of primary or reactivation TB. So usually primary is like less symptomatic, and then most people don't seek attention. And then with the reactivation, X-ray picture will look different, but the may look different, but the patient's kind of like having more like subacute chronic symptoms. Okay. So what are the risk factors of reactivation of TB? So as I mentioned earlier, lifetime risk is 5-10%. Half of risk is it's like for first years after the infection happened. So any immunosuppression from HIV, AIDS, especially AIDS when it's CD4 count are lower, like lower numbers, the chance of TB reactivation go really high. If there is organ transplant, some medications, with some medications actually, they you have to check for the latent TB, like biologics, like right, if you treat like rheumatoid arthritis, Crohn's disease, many of these medications they work by decreasing your activity of immune system. So and then you have to screen for the latent TB. Malnutrition, also risk factor, very young age, less than 5 or elderly, and then different comorbidities, okay, like including diabetes, silicosis, chronic kidney disease, chronic lung disease. Uh, so reactivation TB, so how is it different from active TB, from primary TB? So usually low-grade fever at the beginning, temperatures may rise gradually after that. Night sweats is also present. So cough, getting worse with progression of disease, shortness of breath because of the inflammation. Patients may have pneumothorax infusion. All this basically decreases the volume of functioning lung and will cause the shortness of breath. Anorexia, which is decreased appetite, will happen because of the systemic effects of this inflammation on the body. So here on the chest X-rays, most patients will have some abnormalities, but uh, there will be some which may have normal chest X-rays. So if you're really concerned about TB, you may need to do like CT scan. And then it typically involves upper lobes, may have patch consolidation. Sometimes you can see cavities, and CT is kind of the same, but more sensitive. You may see calcifications, which could be the sign of previous primary TB, which will be suggesting the diagnosis. So this is the reactivation of TB. You can see it's right upper lobe. There is a like patchy consolidation. I don't think there is any clear. You can see the angles of the between diaphragm and the chest wall. The clear. There is no effusion there. I don't see any clear lymphadenopathy. There is no pneumothorax. You can see the lung fields for the whole chest X-ray. So primarily the right upper lobe consolidation. So how do we make diagnosis? So the most like one of the like the most important thing probably you need to think about TB. It's going to be difficult to diagnose it if you don't think about it. So you don't put in your differential, and then you may want to put in differential based on the symptoms, based on the country of origin, contacts. So uh, and then again, as I just told earlier, like it's most of the patients will not have TB, but because it's a public like health risk, you need to think about this disease. Um, and then definitive diagnosis will require isolation of Mycobacterium tuberculosis from the body, fluid, or tissue. So for diagnosis, most of the time, the first step, if it's pulmonary TB, you'll be obtaining sputum for acid-fast bacilli, 3 samples on 3 different days, but as long as it's 8 hours between the sputum cultures, that should be good enough. So it's difficult when even with the mycobacteria present in the sputum, they may not be like in abundant amount. So that's why it could be difficult to see them. That's why you do 3 different sputums, okay? Uh, and then if the 3 sputums are negative, most of the time it's okay, like to remove the isolation, okay? there is no Mycobacterium in the sputum on 3 times, that means that the load of bacteria there is pretty low, and then it's usually means there is a low risk of spreading it. And then what you do with the sputum? So you do AFB smear, which you'll have the result within like a couple hours. You'll do a mycobacterial culture. So it will help to identify the type of mycobacteria, and then different resistant tests to the medications also can be done on the culture. After that, or at the same time with the AFB smear, you will do nuclear amplification tests. It's kind of PCR, okay? So because many times mycobacteria will be there, but they're not enough to be seen at the microscope, PCR test, nuclear amplification will be more sensitive. So even like few bacteria, it will catch it. And it will allow you to identify, to differentiate between Mycobacterium tuberculosis versus some other mycobacteria, okay, through the PCR test. And then the result will be also quickly. It can be also used to identify the specific genes which are responsible for the drug resistance. Not all of them, but some of them can be identified, because this is like, if there's a gene, that means it's resistance. And then it takes a few weeks for the mycobacteria culture to actually grow, and then you cannot do the full old-fashioned susceptibility test until the mycobacteria actually grow. So the specimens where other specimens where you can take like a sample for the mycobacteria is the lung tissue. If somebody is like doing the biopsy, if there is a lesion which you go bronchoscopy and biopsy, it can be a pleural field. If you do photosynthesis, you can do the same, the smear and the culture. And then if somebody has, for example, miliary TB, usually it's a blood. You may find even mycobacteria in the blood, so positive blood culture. Usually, you need to order the lab as a mycobacteria blood culture rather than just general culture. So, a few words about the tuberculin skin test. So, it's not the best test, and it may be negative even when somebody has latent TB, and it can be negative if somebody is really like having active, like a primary TB. It also can be false negative if somebody's immune system is not very active. For example, if somebody has like HIV or AIDS, they may not just like have this like skin reaction because of their decreased immune system. And then usually it's done. It can be done with the control. So in the control, on one side you'll do uh, tuberculin skin test, which is like pieces of the mycobacteria, and on the other hand, you can do just kind of like placebo, and you see like normally the placebo, the control shouldn't be having inflammation, and then tuberculin skin test will have inflammation. So it's based on cell-mediated immunity with delayed hypersensitivity reaction. That's the basis for this test, and then you will inject into the skin. So it's intradermal injection. Okay, so of tiny amount, 0.1 milliliter of PPD, which is a purified protein derivatives. There is no live mycobacteria there. This is just like kind of pieces of the mycobacteria. And then it cannot distinguish between active and non-active infection. So just need to be aware that if any test they ask you, like PPD came positive or PPD came negative, it just shifts your probability one way or another. But it may not help to make like definitive diagnosis. And then there are also factors which may affect the result, like it may be false negative if somebody's immune system is down. BCG, if somebody had BCG vaccine in the past, uh, may increase the chances of positive tuberculin test as well, because there was exposure to the mycobacteria, but it wasn't just, it was different type of mycobacteria, right? And it's read after 48, 72 hours, and then you need, the person interpreting will be reading the actually in duration, not just the redness. You need to measure the in duration, okay? And the interpretation depends on the immune status of the patient. If somebody has a, like somebody has HIV or AIDS, and then for those patients, even 5 millimeters will mean positive. Okay, if somebody has like a normal immune system without significant medical history, then positive will be 50 millimeters. Okay, there's like a list of the diagnosis which you interpret uh, differently. Okay, but I don't think you can remember all of them. So these are the medications for the TB. This is the first line. I think you'll need to remember just like first line medications. It's a rifampicin, is isoniazid, pyrazinamide, and ethambutol. If you go by the first letters of RIPE, it's going to be right. So that's the first line treatment for the TB, and then it's usually started even when before you have all the like sensitivity tests. Uh, and then so the just like few words about the basics of treatment. It's prolonged treatment because the the mycobacteria like sitting there like dormant, and you need like exposure to the antibiotics for a long period of time. You remember some of them sitting in granuloma, so there is no like a lot of blood flow there. So uh, and then that's why it takes time. So the traditional 6 month treatments include uh, the four medications I just like mentioned, which is like RIPE protocol. Um, and here you give all four medications, so you decrease the likelihood of developing resistance because resistance may develop during the treatment. So if you give one medication, you check it's okay, it seems to be working, but like 2 months later, mycobacteria like they develop some mutations and then it's not working anymore. Okay, and then there is a continuation phase, which is 4 months after 2 months. Usually it's isoniazid and rifampin, and duration of change of these phases may change depending on the response. If somebody's sputum remains positive, like analog after 2 months, after 3 months of the treatment, may need to extend the treatment or check for the resistance or like add another medication. So there are other regimens. I don't think you need like to remember them very well because like anytime you start treatment, you'll have opportunity to take a look to check with infectious disease specialists and see the resistance pattern. So there is a 4 month regimen which will include rifampicin, moxifloxacin, and then it includes 8 weeks of uh, rifampicin, isoniazid, pyrazinamide, and moxifloxacin, and then 9 weeks of only three medications. So, and then in any, because you're giving like four medications, up to four medications, patients are more likely to develop different kind of side effects. So that's why you need to regularly look for the CBC, total blood count, liver numbers, liver function tests, creatinine, electrolytes. And these medications also may interact with the patient's other medications. So you need to look like at the interactions of the probability of side effects and then just monitor the treatment. So if you find the resistance to one of the medications from the first line, there is the whole list of medications which can be used as a second line, but they're reserved for those really uh, with resistance or cannot tolerate the medication from the first line. Uh, these medications are the reason they are second line because there's a reason, right? It's either they're more expensive or they are more difficult to tolerate, or they're having more side effects, or they have more interactions. For example, linezolid may give like a bone marrow suppression after like 2-3 weeks or 1 month, so may develop like pancytopenias. Okay, uh, so this is the reference. I think that's it. So questions here? Uh-huh. 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 Yeah. 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 US doesn't give BCG. So the question is why incidence going higher in Africa? Yeah, so vaccine, BCG vaccine, it's not very effective. It's it was there is a multiple studies. It shows that it decreases. I think it's more or less clear. It was shown that it decreases the like mycobacterial meningitis. So for other manifestations of disease, it's like different studies. Like some of them will see like zero effect, some will see like like 30%, 50% effect. So the bottom line, it's not very effective. Why the incidence goes high, I cannot say exactly because I didn't look at the specific data. But if the healthcare is getting more developed and then more people are screened, then at least to some extent, I'm sure it's because of the like finding these patients rather than just like incidents keep going higher. Because that's what happens. So if you start like screening everybody, you find it early, you isolate, you look at the contacts, you track the contacts, like family members, you'll find more people. So with a disease. And is it like you mean like it's more like latent TB going higher or it's like active TB? Which one? No, that's tuberculin test, right? So that's not necessarily mean you have TB. So if somebody had BCG vaccine, then interpretation of tuberculin test could be a little bit difficult. So like I had it myself right twice, like so, and then that's how actually they do. They just give you BCG vaccine, and then if you like MON2 test like is negative, then they give you another vaccine like 2 years later. So until it's like turned positive. So that's why like interpretation could be a little bit difficult. So and if it was, I mean, and in general recommendation, if it was positive at some point, you don't test it again. Then you just either decide, make a decision like to treat for latent TB, which is a little bit different. It's just a few months of only two medications. Uh, yeah, and it's a general recommend because the lifetime risk of 10% is considered high enough to do the treatment. Many people will not do will not accept the treatment because it's bit like you may have like side effects from medications. So, but once you have positive BCG, I mean positive tuberculin test, you just like look like screen for the symptoms. That's what happens in the hospital, right? If you had it positive, like and like your employee, you work in the hospital, just once a year they'll send you like the questionnaire. So do you have like night sweats, like weight loss, like cough going on for more than a month? And you answer positive, like for any of them, then they'll do more screening, like chest X-ray will be the next step. And then depending on how highly concerned you are, but this is just for model screening, okay? Mm. So malnutrition affects, I think if you have malnourished, so what it does, you basically have kind of your immune system is down. So you don't have enough like antibodies, right? It's a protein. So if you don't have enough protein, like energy in your body, your immune system not gonna work very well. So, and then you'll probably have high chances of primary TB, but the problem will be that they'll have high chances of like reactivation of TB. So, but malnourishment doesn't happen like it may happen at a certain point in your life. So that's why if there is a malnourishment, then you will again like have high chance of reactivation. But malnourishment, remember, like is not always the weight. Okay, so somebody may be like overweight, but maybe malnourished. So it happens, especially in the hospital. Like I think in the general public, it's not very common, but in the hospital, if somebody gets sick, uh, the albumin, like all the protein levels, go like 50% of normal range. And if somebody was obese, like stay obese, but the immune system is not working that well. So, mm, mm, mm. So I think it may help if it's like negative. Uh, so especially if it was negative and you turn positive, then there is a little bit high chance that now you like kind of contracted it. Uh, so then it may be helpful, like more. But again, if you turn positive like 10 years ago, right? So you already like your reactivation was the highest for like for the first like 2-3 years. So now you chances for reactivation for the rest of your life is maybe another 5%. Yeah, it's possible. Yeah, it's difficult to interpret. That's why it becomes like unclear. And then I think people, yeah, yeah, yeah. No, I have the same problem. So myself, because I got BCG, I think at least twice. You actually have a scar there, so that's how you know. So, uh, but it makes like interpretation a bit difficult. So I think I had both like negatives and positive myself, right? So I didn't take treatment for latent TB, although it's like the because like if you go to areas of the high incidence of TB, like there is a chance you'll get it again. So that's like, but the general recommendation, even for those patients who are getting back to their like motherland, like where they were born, like Africa, Russia, whatever, like it's still a recommendation to treat the latent TB. But I think a lot of people still not going to do it because like you have to take the medications. But the interpretation, like for your specific situation, becomes difficult. So because they did it the right way, did they put the control or didn't put control? Uh, hmm? I think quantiferon is a little bit better because I don't think it will react to BCG. So I think it's so BCG will not affect. So you may consider repeating like with the BCG, and it's also less like like it's less dependent on the interpretation of the test. So sometimes it could be like 4.5 millimeter, right? So somebody will say it's positive, somebody will say negative, uh, and then again there could be like just local reaction from the skin, not necessarily like specific to tuberculin, but just like you inject anything in your skin, it's going to be like red and indurated, right? So that's why you do control, so you can see what happens with the PPD versus like just like control. Control is usually some I think candidate proteins there, but gamma interferon release test is could be one of the options like to do. Come, thank you, thank you.